morning, ladies and gentlemen. I'm Adeline and this is Ivy. Welcome to 6th National Myeloma Patient Forum. A big thank you to all our speakers and you, our attendees, for taking time out to join us this morning. Before we start out, we would like to thank our sponsors for the forum this morning, Celgene, Janssen, and SkyQuest.
For those who are joining us for the first time, this is the 6th year we are organizing this event, and through this event, we hope to reach out and to provide myeloma patients and caregivers with more information. And more importantly, we hope to provide a platform for patients and their caregivers to interact and to share experiences with one another. So without further ado, let us now invite Prof Chng, Director of NCIS, to say a few words. And following on, Prof Chng will be the first speaker for the day, and he'll be sharing with us, Cure for Myeloma, Are We Close? Prof, please.
So good morning, everyone. It's very nice again to see, so many of you coming to join us on a Saturday. I think this event, as we said, is in its 6th year already, and I think the number of patients we have coming to join us, keep increasing year on year, which is a good sign, which means that the patient, are really living longer with this disease and able to come to join us. Some of our patients here have been with us for all 6 years that we have been running this. And also this year we have some visitors from Indonesia as well. I mean, the Indonesia group is forming a clan. They're sitting right amongst you all. And so this is good. We're forming a community. And as I always said in the past, I think this is our myeloma family. We're here to support each other. Our jobs as the physician treating you all is to make sure that you get the best treatment available to you, and we take care of you during your treatment. But there's many aspects of your life that is outside the treatment, outside the hospital, and this is where the other support systems come in very useful, to have friends who is going through the same things, to be able to talk to other people that are sharing the same experience. I think those are very, very important aspects of living with a condition. So I think without much further ado, I shall start the program with my talk. I always like to be a bit provocative and would like to kind of, through the talk, share some new things that's happening that perhaps will give our patient more hope and encouragement. So this is a very provocative title, Cure for Myeloma. I think every one of you who were initially diagnosed with myeloma, and the same thing for my patient, I would usually have a difficult time telling them that they actually have a condition that is still currently, not curable, in the sense that we cannot get rid of the disease completely. Even when we do, the disease tends to come back after a number of years. But we do have many, many good treatments that we can keep giving the patient. And as a result of that, many of our patients live for a very long time. And so it's becoming like a chronic disease for majority of the patients, like high blood pressure, diabetes. We cannot cure these conditions, but they have to take medicine, all the time. But the treatment itself is not too disruptive to their life. Many of our patients on treatment actually go back to work. We have teachers that are working. We have people in the finance sector that is working. We have people who are doing triathlon, cycling as a hobby, that after treatment can go back to a very high level of physical activities. This just goes to show that, in many, many patients, this is becoming, the norm, right? So it's not a disease that we should be very, very scared of. It's a disease that we can do a lot for. Many patients are having very fruitful living, living with the condition. But still, we don't want to stop there, right? We want to keep pushing the research and keep finding better and better treatment for our patients so that we can see whether one day we can cure them or not. And there are some encouraging data and some encouraging trend. The field of myeloma is progressing all the time. Every year at the major international meeting, we are seeing new drugs being tested, some of them being approved by the FDA and soon to become available in Southeast Asia country. So as we treat our patients, if there's continued progress, better and better treatment, there is always bigger and bigger hope, right? So I think this is my job, actually, is to update the community on what's happening. So are we really close? And the truth is that we actually are already curing some myeloma patient, although that is a small percentage. Okay, and this is a very busy slide. I want to just highlight this red curve here. This is data from France. Okay, and you can see here are data actually from different countries. The different countries are doing a bit differently, right? But in some of these more advanced countries who have patients with longer follow-up, you can see the blue and the red lines, they have got small group of patients that's living, this is in years, more than 20 years. Okay, and so these people who are living more than 20 years probably have a high chance of, living and dying with myeloma from something else. They could be maybe dying from a heart attack, from a stroke, from some other chronic condition, but they are not dying from the myeloma. Okay, so you can see that this is the case. And based on some calculation, what they found is that about 20% of patients are probably getting, so-called living for more than 20 years and hence potentially so-called being cured from the disease in complete remission without any disease. Okay, so this is the current situation. Already, there are some patients that are living very, very long time. Even in Singapore, my patient, Dr. Satish's patient in SGH, we have patients that have lived for a long time, So the important thing is, who are these patients? Are there some special features amongst these patients? Or was there something unique about their treatment that make them like that? So that's the next challenge. The good news is that we do have some of these patients. The next challenge is that how do we have more and more of these patients, right? What's the secret ingredient here, right? And so that's the next step of the research that we have. But over the years of doing studies in myeloma and clinical trials and research, we have also learned a number of things that can further help us to increase that percentage of patients that we could potentially have cured. So what have we learned? We have learned that there are patients, you can see that this means 100% of patients with myeloma, there's a steep fall off. By 5 years, more than half of the patients, or about half of the patients would have relapsed disease and have problem, with their condition. So these are the early relapses. And then there are some that have a late relapse, and then some actually are not even relapsing, right? So I commonly have questions from patients who say that, hey, how come, I'm like that, my friend with myeloma is not the same as me, why are they not needing treatment, whereas I need to continue to take some treatment, do I need to worry if my friends have treatment and I don't have treatment? The important thing here is that really these are all patients on the same treatment, roughly, right, or very similar treatment, but they have very different outcomes. So myeloma is very different. Individual myeloma patients is different, just like how we are different, in fact, individually as well, right? Some of you are tall, some are short, we're all different. So it's not just the human, the host is different, but the disease that is in us is also different. Okay, so we cannot directly compare, and so when I say, support each other, talk to each other, it's not really compare your notebook on treatment, his dose is a bit higher than me, so am I losing out, how Asians are a big yasu, so he has 10 milligrams, I also want to have 10. But if you have 10 milligrams, you get side effects. The guy doesn't have side effects. So this is the difference. So one thing important to note is that everyone is different, okay? So it's important to know that, of course, if you see things that are done differently, it's quite within your rights to ask the question, why am I different, and the doctors will explain to you, but it's to realize that everyone is different. So our job is to identify these early relapse patients and see whether we can do something to prevent them from relapsing early or not. And here, those late relapse, again, whether we can do something to prevent the late relapse, right? Because we don't want relapse. If there's no relapse, the patient is living longer without the disease, right? So we know the trends. We know that there are the groups of patients. So how do we identify these groups of patients? And we have good methods now, and these are tests that you all have done when you have diagnosis of myeloma. You have your genetic test done. You heard people talking about ISS, International Staging System, beta-2 microglobulin, and so on. So these are things that we use and we check at the beginning to see whether you are patients that are high risk of early relapse or you are the standard risk that tend to relapse a bit later, right? And with your treatment also, we'll see how your response are. Some patients respond very well, very fast to treatment. That's usually a better sign. Some patients are more resistant to treatment. That may suggest that the disease, despite the fact that they may belong to a standard risk, may have something in them that make them more difficult to treat. Then straight away they become also a higher risk patient. So at the beginning, as well as how the patient responds to the treatment, will give us additional clue to whether they are someone that is likely to have earlier relapse or longer time before the relapse. We also know that the depth of response, so again, this is a cartoon. Here in this axis, 1 means when you have all your myeloma at the beginning, right? And down here means 0, no myeloma, eradicated, okay? Is that if the response is deeper with treatment, your survival is longer. So this line this is the relapse, okay? When they do an upswing, this is the time of relapse. So when you treat and the patient have much deeper response, they are correlated with longer survival. Doesn't mean that every single one of them that reach here will survive 20 years or so. It doesn't mean that, right? So again, that's an important thing to remember, is that again, we are able to only advise patients based on averages and what is likely to happen. It's like buying securities and investment, right? This is not 100%. It's not like you buy baojia, this one sure cure. No, it's not. Even if you have all the characteristics of a good patient, it just means that it's associated, right? So it doesn't mean that everyone will be like that, but majority will be like that if you hit this. And this should be the target that we try with our treatment, but not every patient is possible to achieve this, okay? But the important thing is we have now better methods to go and detect lower and lower level of disease so that we can be more precise in checking whether you still have myeloma or not, to be able to tell you whether you're in good shape or you may be likely to come back earlier. The important thing here also is that myeloma, as you know from here, is that a disease that even here we need to continue to monitor the patient. So one important thing is that when you have a diagnosis of myeloma after your treatment, you need to continue to go and see your doctor. The danger is sometimes patients feel very well now, I'm back to work, I don't want to go and see the doctor anymore, they don't really do much for me except tell me my blood result is okay, so I'm wasting time going to see them. No, but you still need to go and see them. You need to have your blood tests checked regularly, because why? When the disease comes back, we want to pick it up early before it starts to cause any problem to your body, like cause your kidney to fail, your bone to fracture. We want to catch it early so that we can retreat it early, and the patient will tend to respond better when they get retreatment early. And so this is the important part also. We have many patients that sometimes they don't go back to see their patients. Then when they come back, they're very sick already. Disease is very high. Then you are trying to play catch up, and sometimes the catch up not in time. Then you lose your chance of having another good remission after that. So maintaining follow-up is very, very important. The other thing that we learned from the past is that it's not just achieving this complete remission, because if you achieve a complete remission and you lose loss of complete remission, this green line, the patient actually do worse than patients who never achieve complete remission here. And the best guys that do the best are those that can sustain their complete remission for a long time, okay? So this may suggest that we need to give patients continuous treatment, okay? And there's some data that suggests that that's the case, but we don't do that for all patients because, again, you can see that here, even those, in later slide I will show, even those patients that are on continuous treatment, some of them will not be able to sustain that CR. So the important thing here is that we need to find and choose and pick who are the right patients to give this kind of treatment. Because why? Sustained treatment with expensive drugs. I think all of you had myeloma treatment before. You know how expensive the treatment is. If I tell you, you need to treat for the rest of your life with a drug that costs 10,000, 15,000 per month. Some people will turn around and say, no, thank you. I want to live nicely for 1 or 2 years and then close shop. I don't want to live so long and be a poor person, right? So that's the other challenge. We know that some treatment may help our patients, but they're very costly. So how do we actually optimize it, select the right treatment for the right patient, and make sure that they have the maximal benefit. Can we work with charitable foundation to help with some of the poorer patients? Can we work with pharmaceutical company to, again, help some of the poorer patients? So these are the challenges, for us, not necessarily so much for you as a patient, but you always worry about the cost and the side effects of long-term treatment, right? And then the other thing we know is that why do some of these patients relapse is that they have these drug-resistant cells. So most of the time when we talk about the myeloma cells are these so-called plasma cells right up here. But in some patients, they have earlier cells. Okay, so these are cells that are earlier than the plasma cells that are hidden. Okay, they are like a bit like these terrorists, right? That they are hidden, they're camouflaged, they're not easily visible, they look like normal cells, they're small in numbers, guerrilla warfare, so they hide away, right? And your treatment is killing off these guys. But there's some of these guys that are hidden that over time, when the environment is nice, they cause trouble again. They come back and they expand, right? And we know some of the characteristics of these cells. For example, these cells tend to express some markers like CD38. Okay, remember this CD38 because it may become relevant later. Okay, whereas you can see here that some of these other, the normal plasma cells also, the mature plasma cells also have CD38, but the earlier one would not have some of these markers like 138, this is positive, here is not anymore, but 38 is there all the time, right? So the earlier cells also have CD38, okay? So based on that knowledge, right, this whole issue about deeper response, we need to pick up patients with early relapse, those sustainable response do better, there are some hidden cells that may be causing trouble later. What can we do? What can we do? Okay, how can we increase this cure fraction? So I think 5 steps, basic steps that we need to address and look at: early detection, pick up the myeloma earlier before they start to cause damage to our body. Okay? Better drugs, you can talk about all these fancy things that you want, but you only have one drug, useless. You can't do much. So we need better drugs and more drugs, right? Drugs that can eradicate these rare cells that I say, CD38 is expressed in the earlier cells as well as the late cells, but some other markers are not, okay? We need drugs that can eradicate some of these cells. Better ability to measure deep response. We want to know who are the patients that we can get into the deepest response, and we want to see whether our treatment can get us there or not. And how to sustain this deep response. So do we have the tools to do this? The answer is we have all the tools actually now, right? All the 5 steps, we have potential tools. So that is the hope for us in the future. There's a very important new publication here that was just published late in 2014, is that we now have markers like these ones that can pick up myeloma patients that require treatment and will benefit from treatment even before they develop any symptoms of bone disease, of renal impairment, of low blood count. So we have these parameters, okay, when the creatine clearance is a bit weak, they have high levels of plasma cells in the bone marrow, they have high free light chain ratio, they have some lesions on MRI, which is a very, very sensitive method of looking at bone lesions before they have pain and so on, right? So now, when someone has a MBAN or has abnormal protein in the urine, and we have one of these things, we'll treat them early. We won't wait until they have proper kidney failure or bone problem or anemia. So by treating them early, we hope that we would treat a disease that is still quite amenable to treatment. That means they haven't developed these resistance mechanism, additional protection to the cancer cell that make them harder to kill, okay? So that's one thing. And we are actively actually looking for some of these markers in patients that appear to be quite normal but have an abnormal protein nowadays. The other thing is we have better drugs. So one of them is this drug called carfilzomib that was approved, okay? And we have, in fact, a remarkable year last year. In December 2015, the FDA approved concurrently, I think 4 drugs for myeloma treatment. So one of them is carfilzomib. Then there is another one called ixazomib, which is also a proteasome inhibitor that's taken by tablet. Some of you would have had that treatment before on clinical trial. Some of you, I am actually arranging for the drug to be available for you at the moment. Okay, we have better drugs. Another one is elotuzumab. Another one is daratumumab, is also approved for certain indication. Okay, the problem with us is that we don't see these drugs until 2-3 years down the line. You know, our friends in Europe and America, they can use these drugs straight away. Now that the drug is approved, it's available. For Asia Pacific, it's a bit of a wait time. So what is our strategy? Our strategy is to, on a few accounts, one, work closely with the companies to see whether they can get the drug on named patient program, special program for our patients early. Sometimes that's not possible. If it's not possible, then what we are doing is to make the drug available to our patients on clinical trials. When I say we, in this regard, is all of us, including General Hospital. You know, we have formed a consortium which actually will work together to bring drugs or good clinical trials to patients that utilizes some of these new drugs. So that is the best way for patients to get early access to these drugs, because most of those time the drugs will be free. Number two is that the patient will be closely monitored on a clinical trial setting where there's regular blood measurement, follow-up for side effects. And number three is actually benefit other patients, because it will allow us to collect and the data that will tell us how to use these drugs in Asian patients. Is there something special about our Asian patient? Who are the patients that respond better to this drug? So sometimes our patients are very scared when we tell them that, oh, you know, we have a good clinical trial for you. Do you want to do? They say, no, you're going to experiment on me. I'm like a guinea pig. I don't want. You know, but no, in fact, it's opposite, because it is true, some clinical trials you are in a way like a guinea pig because the drug has not been really used by many humans before. So these are the early human clinical trials. But the trials that we're talking are not like that, because why? You already know these drugs are approved by the Americans and Europe. You know, it's not new anymore. Thousands of patients have already been treated on this drug, right? So you can at least be more reassured that these drugs are actually relatively safe. Of course, the experience in Asian patients may be less, but you can also be secured in the sense that this is in a monitored situation and you can stop at any time if you don't feel comfortable. Okay, so I think partly is educating our patients on the usefulness of clinical trials, and you shouldn't be afraid to join the clinical trials, because this is one way our patients will get many, many treatment options. And for myeloma, a disease that is generally still not curable, the ability to get access to many, many different drugs is very important. Okay? Just imagine if you have 10 weapons and you choose to only use 2, because the other 8 weapons you're not sure how to operate. Then you're shooting, you're disadvantaging yourself. So I think this is an important message to get out there. We have other drugs, like I said, this daratumumab, right? Anti-CD38, you see? So we have drugs that can kill all the cells that express CD38, including the earlier cells that can trigger a relapse because they are more drug resistant. So we have this that is coming online, not yet available. We are planning a clinical trial using this drug. In fact, we're planning like 3 clinical trials. We're not sure whether we'll get any one of them to Singapore or not, but we're planning trials to use this drug for our patients so that they can have early access while the drug gets, wait for its approval with our authorities, health science authorities. We have ability to measure these deep response. As I said, this is again another way to look at it. At this top here is when you have all the myeloma, and down here is where you have very little. And you can see that at the moment, our way of looking at M-band and so on, we can only detect up to around here, which means that there are people that we think are already in complete remission. They still have some disease, right? So what are these patients doing? It is not to say that all patients with disease will be bad news. We also have many, many patients who are a bit more on the elderly side, a bit older, 70-year-old, 75-year-old, that we know we can never get rid of all the myeloma cells, because don't forget, the so-called myeloma cells, they can exist in old patients without causing problem to their health. Okay, so this is a phenomenon that we see in older patients. Okay, so very often we treat, we may come down to a bit of protein that is left, but that is not going to cause any problem. So, it's not always objective to treat until here. We may have patients that are here or here that actually is going to do quite well. So the challenge again is to identify these patients. Okay, so I don't want to give the message that tomorrow you go and tell your doctor, hey, I still have myeloma. Keep giving me more treatment. We know of patients with a little bit of myeloma that doesn't do anything for them for 5 years, 10 years. Some of my longest survival actually is living with small amount of protein. But they're happy. They don't have any problems. So it's important to check also the progressions of these proteins. What are they doing? Are they remaining quiet? Are they going up? How fast are they going up? And then see whether we need to do anything for them. So we are looking at some of these issues, treating the high-risk patients. So this is a trial that is started by Dr. Satish from the General Hospital, and we're all participating in this. So this is one such example of what we are doing to try to address some of these issues, right? Treating the high-risk patients a bit differently because we know that they tend to relapse early, so we want to give them a different treatment, more stronger treatment up front with a better, newer drug, carfilzomib, I said before, Kyprolis. Then we want to measure their disease status with an MRD, very deep response, and see if they have still got some disease, if we give them continual treatment, whether it will help them or not, right? So we are starting to think of this, okay? So again, if we don't do anything, we'll always just stop there. So what our principle is in Singapore with our study group is to keep thinking of better and better studies, better and better ways to learn about the disease to help our patients. Okay, so these are some of the efforts that we are putting on. Okay, and the other aspects I said is to maintain the response, right? So the maintain of the response is using continuous treatment potentially, right? So this is one such example that is very high profile publication. They show that if you use a continuous treatment with this lenalidomide, you have better survival. So by now you should recognize that this line that is high is better than the line that is low, okay? Just simply remember that. So whereas if you have other treatment that is not continuous, you actually don't do so well, right? So this suggests to us that continuous treatment may help patients, okay? But the important question to me is that what are the important drugs to use for continuous treatment? Okay, is it Revlimid, as shown in that study? Is it other drugs like thalidomide? Is it drugs like carfilzomib, which we are testing, Dr. Satish is testing in this trial? Is it other new drugs like ixazomib? What is important for us to consider? Is it the how effective it is? Side effects? How is the drug given? Some of these drugs are given as injection. So for maintenance treatment, if we tell someone to continuously have this treatment for 4 years, 3 years, 5 years, is it convenient for patients to keep going for injection every week? Is an oral tablet better? Right, so all these are still major questions that we need to answer, but the idea is sometimes with continuous treatment, it may help, okay? So the data is still being generated. So I think the aim here is to increase this cure fraction. And I think with all the work that is continuing to be done, with the better drugs available, better techniques to detect disease, better idea and understanding of the disease itself, why do patients get relapse and so on, I think we will continue to make progress. Okay, I can tell you that this line 5 years ago is probably nothing. It's not like that. Now it's like that. And I think going on in the future, we will continue to make inroads into here so that it keeps going higher and higher. The encouragement for patients is that as long as you're feeling well, your disease is under control, there's always hope. Because every 1, 2, 3 years, there's new drug, right? So I think this is the main message, is that we are doing our best as physicians, scientists, and you have seen over the last few years there's major progress, and this will continue. I think for our patient is to continue to work with your doctors to get yourself better and to have hope and to live with hope. So with that, I finished, I think, my presentation already. And I've already taken up a bit of Dr. Satish's time. I shouldn't do that anymore. So without further ado, we'll have Q&A later, I think. So I'll ask Satish to come and tell us about some new drugs, probably in more detail than I've done. I've just briefly mentioned a few so that you know.
Thank you, Prof Chng. Our next speaker is Dr. Satish, consultant from Department of Hematology, Singapore General Hospital. So today he's here to share with us more about newly approved drugs in myeloma.
Good morning all, and thanks for being here. So I've carefully chosen again Dawn of a New Era because there have been some important developments last year. It was a bumper year for myeloma doctors and patients. So I think I'd like to spend a bit more time on the new drugs that were approved last year. So before we start, I'd like to go through the history of development of drugs for myeloma. And if you see, in the beginning, in the early 1960s, myeloma was a disease which was fatal in most patients and would be a very fast one because we didn't have any good drugs. So you can see that, in the beginning we had simple drugs, tablets mostly, melphalan, steroids. And the major breakthrough came first time when they used high-dose melphalan, which is the part of chemotherapy that you get for transplantation. And that was first trialed and published in 1983. But then they found that people had very high risk of death because they had a long period of low cell counts, and they were getting infections and were dying because of infection. And it was later that somebody figured out that maybe we should collect stem cells before that and store it, and then infuse it later so that we can reduce the duration of low cell counts. So that's when the transplant, as we know now, came to existence. And it has been the standard of care ever since. And even to date, no studies have really shown that transplant can be beaten in at least in clinical studies. And then we had, other small changes happen. The other big thing that happened was that understanding that bone damage is very crucial and debilitating in many myeloma patients. So we started using bisphosphonates, which is, either pamidronate or Zometa, as we know. And this, again, started around that time. But there's a line here, and after that, I would call it novel agent era, because the earliest novel agent era drug would be thalidomide. Because before that, we had chemotherapy that would kill good and bad cells alike and cause a lot of collateral damage. But the novel drugs were targeting unique things in cancer cells, trying to avoid collateral damage. But thalidomide had a lot of side effects, especially neuropathy and constipation and sleepiness in patients, especially elderly. So